Welcome to the Virginia Opioid Abatement Authority Abatement Academy. This is an event that's sponsored by the Opioid Abatement Authority, or the OAA. The purpose of the OAA is to abate and remediate the opioid epidemic in the Commonwealth through grants that pay for the efforts to treat, prevent, and reduce opioid use disorder and the misuse of opioids in Virginia. The OAA's Abatement Academy is a series of free webinars with information about best practices that cities and counties can consider when developing strategies to fight the opioid epidemic in their communities. We focus on initiatives that are allowable uses of the opioid settlement funds. So the things we talk about in the Abatement Academy are all things that can be paid for with these settlement funds. Each of our webinars is recorded, and the recording, along with any presentation materials, are then uploaded to our website at voaa.us. V as in Virginia, voaa.us. Ellen, if you would go ahead and advance to the next slide, please. So this morning we're joined with a panel of experts from 3 different fire and EMS agencies across the Commonwealth of Virginia to talk about approaches that fire and EMS are taking to help people who are struggling with substance use disorder get connected to treatment and recovery. So joining us on the panel from Roanoke City, we have Jason Focht, who's a captain in the Fire and EMS department, and Miss Christine Wright, who's program manager from Bradley Free Clinic. And you'll hear more about the Bradley Free Clinic in a moment. From Chesterfield County, we have Lieutenant Mike Abbott, who's program manager for Chesterfield's Integrated Healthcare Program, along with Dr. Alan Yee, the medical director for Chesterfield County Fire and EMS. And then from Fairfax County, we have Captain Steve Hartman and Miss Ellen Volo, who is Fairfax County's opioid response manager. And then I've already introduced myself, Tony McDowell, with the Opioid Abatement Authority. Next slide, please. At this point, I think we will turn it over to the folks from Roanoke. Jason, I think you're on mute.
Hey, good morning. Sorry about that. Thanks for joining us. I wanted to make sure that everybody can hear me. Thanks, Tony, for jumping in there. So this is just an overview of the city of Roanoke. You can see our population size is about 100,000 people, about 46 square miles, with a department size, a fire and EMS department size of about 280 full-time personnel, responding to about 31,000 incidents a year out of 11 stations. You can see down here in the bottom that in 2023, we had approximately 728 overdoses. That number does include things like overdoses, accidental overdoses from children. We did not have a good means of differentiating narcotics overdoses during that time period. But since then, in 2024, you can see between the first 6 months of the year, we had approximately 400 overdoses, and 251 of those were narcotics based. So you can see here that we certainly have a need for the programs that are in place and the things that we're doing to try to overcome this epidemic. Next slide.
Good morning. I'm Lieutenant Mike Abbott with Chesterfield Fire and EMS. Like we said earlier, I have along with me Dr. Alan Yee, who is our Operation Medical Director this morning. Just a little bit of overview for Chesterfield County. We have a population size of around 390,000 residents, over 437 square miles. We're a very large county. We have 659 career personnel in our fire department. 23 fire stations, cover 4 battalions, 23 engines, 6 ladder trucks, 19 transport or ambulances, and 3 peak demand units that are in operation on a weekday basis. We also have 7 volunteer rescue squad stations. That is a total of 4 rescue squads. They have 7 stations. We in 2023, we ran over 55,000 incidences in Chesterfield County. The fiscal year 2024, we had 303 calls that involved overdose that we administered Narcan on, and our operational units do leave behind Narcan through the VDH program, and in fiscal year 2024, we left 98 Narcan kits behind at different overdose calls or other calls related to overdose of opiates. In Chesterfield County, I'm the program manager for our mobile integrated health unit. We have 5 fire department personnel. 4 of those are paramedics, and 1 is an EMT. And then myself, I'm also a paramedic. I manage that program. Our SUD patients referred to MIH in fiscal year 23 was 244 patients. In 2024, that number went up to 289. And we'll talk a little bit about our Suboxone Bridge program later, but our Suboxone Bridge cases for fiscal year 24 was 38. And we're already up into the double digits for that Suboxone Bridge for this new fiscal year. All of our referrals that we get through to MIH come from 911 follow-ups. So our operational units run 911 calls, and they'll refer these patients to us. Our community partners, which is our mental health and other services within the county, area health systems, as well as several other areas of Chesterfield, citizens, and pretty much anywhere that somebody can get a hold of us, they can refer a patient for not only overdose or SUD services, but for other services as well. Our mobile integrated health program, as it relates to our SUD efforts in Chesterfield County, we have a very strong partnership with our folks over at the CSB and our mental health partners in Chesterfield County. That's started back in 2017, where we had an actual peer recovery specialist that was embedded in our program. That peer recovery specialist has since been moved back over to the CSB, and they're not embedded in our program anymore. But we still collaborate on a daily basis with our CSB partners. We have a very strong program and partnership with them where we receive our referrals for SUD through our MIH office, and then we collaborate with a peer recovery specialist and an MIH provider, and that peer recovery specialist partner up, and they develop a plan to engage the patient and look at all the services that they can provide that patient. They will go out to the location or the patient's home or wherever they were last contacted and attempt to make contact with that patient and offer them recovery services, harm reduction services, as well as other services that the CSB peer has access to. Each of our SUD referrals is attempted to be dealt with within 24 hours of receiving that, depending on the day that it comes in. I go through all those referrals and I distribute those to our providers on a daily basis. We have numerous public safety peers also in the county as well, or at least one that works through our both our police department and our sheriff's office, and she also is somebody that we rely on a daily basis a lot of times to help us through our SUD cases as well.
All right, moving on to Fairfax. I'll read the slide to you, but obviously a little over 400 square miles, about 1.2 million people, fluctuates a couple 100,000 a day, depending on commuter traffic. We operate at 39 stations with 43 transport units. We run about 120,000 calls a year and transport about 70,000 patients. Compared to Chesterfield and Roanoke per capita, our opioid numbers aren't quite as high, but we do still have a significant opioid problem in a population that we are trying to get services to. So in fiscal or calendar year 2023, as you can see, we break it out by acute opioid overdoses and then opioid complications, whether that's withdrawal symptoms, cellulitis infections. So a little over 400 actual overdoses and then 400 little over 400 other related complications. In terms of our population, we are in geography, we are very diverse. We have everything from rural farmland and horse estates to high density urban areas with 500-foot high rises and subways like Tyson's and Reston areas. Everything from multi-million-dollar estate homes that sit on dozens of acres to significant portion of low-income subsidized housing. And one of the other challenges that we're also trying to address as we address the opioid problem within the county is that we are a very diverse county. There are over 140 different languages spoken in Fairfax. Opioid use disorder knows no bounds, whether by age or gender or race or ethnicity. Some of our youngest patients are under age 12 and our oldest patients are approaching age 80. All right, so moving on to the next slide. One of the things we wanted to talk to the different EMS agencies participating today is taking advantage of the unique role and the position that we're in, being on the X, so to speak, being at the location in the home environment where the patient's residing, where their place of employment, being there, being engaged with them on that X makes our time with them more salient than pretty much any other provider in their chain of care. And we'll talk more about this later, but we talk to the patients at the scene and offer leave behind kits, just like Chesterfield and many other EMS agencies do, and offer connection to peer support services. And we'll offer that during any point during the incident, whether it's at the scene, whether it's during transport, even at the hospital, if that makes more sense. But what we've seen over the couple of years that we've been doing this is they seem to be much more receptive on the X at home, wherever the acute overdose has occurred. Immediately after their overdose, you know, that near-death experience for many of them, we have their undivided attention, for lack of a better word. And as more time goes by, they tend to be a little less receptive. Their symptoms return. They might be thinking about trying to find more opioids. They may be thinking about life or work or other consequences, such as the family, friends, the struggle. And that's the struggle that many hospitals face. You know, a couple of hours after the acute overdose, they're thinking about eloping. They're not as attentive because they have other things on their mind. So we need to capitalize on that, you know, opportunity that we are provided. In terms of potential value or benefit to the patients, leave behind Narcan is much more likely to be used and much more effective when we provide it to somebody sort of in the orbit of the person with opioid use disorder, be it a friend or a family member or a roommate. They're much more likely to have access to them on the scene than potentially a nurse or a doctor will at the hospital, because a lot of times those friends or family members don't accompany the patient. And then even if the patient declines connection with a peer support or other services at the scene, oftentimes a friend or a family member will come up to us and say, hey, can we get their leave behind kit? Or, hey, can we get information on how to get services? Because even if the patient's not ready to get help, a lot of times the friend or family member or roommate, they want that information. And Ellen, next slide. And just real quickly, this is a dashboard that our data analytics division has put together to help us track the dispensing of leave behind Narcan kits. And this just shows you, if you click one more slide, Ellen, that if you look over on the right-hand side, the vast majority of the kits that we dispense are actually to friends or family members, not actually to the patient themselves. And to us, we actually think that's a good thing because they're actually more likely to get used. And Ellen, next slide. And then over to Chesterfield, I believe.
Yeah, this is just it. So this is just a follow-up slide to just some of our harm reduction efforts that we have here in Chesterfield. So to piggyback off of what Steve was saying, we have leave behind naloxone kits on all of our fire units, engines, trucks, as well as medics. Any provider at any time can engage either the patient, family, friends, and leave behind a Narcan kit. We have patient and family resource cards in those Narcan kits, as you can see in the background there, with a QR code that provides that layperson or family member or patient the ability to look at a video that instructs them on how to use the Narcan nasal spray. Our follow-up for our OD and naloxone administration calls We go, like I said before, we do that through MIH and a peer recovery specialist. We also, as a MIH provider and as a peer recovery specialist, have access to leave behind Narcan kits, as well as test strips for both fentanyl and the xylazine from our CSB and our peer recovery specialists. And I will leave the we do the same day Suboxone inductions through MIH as well. I was going to leave that for Dr. Yee to talk about in a later slide.
Okay, Ellen, next slide. One of the things that I wanted to talk about was trying to get buy-in, and specifically getting buy-in with the EMS providers within your agency. We all know that within fire and EMS, as well as society as a whole, there is a full spectrum of opinions on just about everything, including those with substance use disorder, opioid specifically, and is no different. So as we were preparing to roll out our opioid use programs to the field and EMS providers, we spent a fair amount of time talking about how to get buy-in. And so what we ultimately ended up coming up with, recognizing that we had 1,700 providers to train, is we got our medical director to do a very brief but sort of high value, sort of impassioned video on the medical nature of addiction, specifically focusing on how it's a disease and not a moral failing. But then most powerful of all, many of us consider her a friend, had a nurse that we all knew and had worked with for years at one of the busy level 1 trauma centers in the area, who suffered from opioid use disorder and is now in recovery, who offered to do a video for us to share her story. So brief summary of what happened. She had an unexpected death of a parent, coupled almost immediately with an on-the-job work injury. And she was prescribed Percocet for that injury. And then as soon as she took the first Percocet, she told us that she got immediate relief from both the pain of the injury and the anxiety and the stress and the grief that came from the loss of her parent. And as a longtime healthcare provider, she knew that was not normal. But she was so desperate for relief and to be able to function again in her job and in her life, she sort of put that to the side. But then very quickly, when the Percocet ran out, the pain and anxiety returned, and that quickly devolved into diverting narcotic waste at the hospital. And one of the things she wanted to emphasize is nobody knew for the longest time. During that time that she was using and diverting, she received multiple nursing awards and even a promotion at work. And it went on for over a year before she was caught. She tried to kick the habit on her own without success, and then losing her job, she had resorted to heroin. Ultimately, she did 28-day inpatient rehab and medication-assisted treatment with Suboxone to get clean. And after a decade, she's managed to get her nursing license back and is back on her feet. And she's a success story. And not everybody in our department knew her, but listening to her tell her story, many of us knowing her and sort of word of mouth sort of discussion about it, I can't say it changed everybody's opinion, but it changed a lot of people's opinion. And I know that Jason's got a similar story that he can share down in Roanoke. But if you can make that personal connection, if you can make that emotional connection with providers, if you're not off, if you're looking to expand your opioid services to the patients that you encounter, trying to make that connection, I think, does wonders for getting buy-in from your field. Chesterfield, Roanoke, do you guys have anything to add? Jason, do you want to talk a little bit about how you came here?
Quickly, Steve.
Okay.
So I look at this a little bit differently. From the fire and EMS background, back in 22, late 21, I was serving as an EMS supervisor, and I was seeing a tremendous amount of overdoses every day, multiple times a day, frustrated, angry, mad, didn't understand. So I think in fire and EMS, we typically see the worst of the worst. We see the overdose, we take care of the immediate issue, we take them to the hospital, and that's where it stops for us. We don't see the recovery, we don't see the outcomes, we don't see the success stories that comes with recovery. So I was doing some other things within the city of Roanoke, working on a few projects. I visited Chesterfield and their MIH team, learned a lot of cool things. And that was my first exposure to peer recovery specialists. And that was in September of 22. So I came back to Roanoke and met my friend Christine at a peer recovery meeting in Salem. And that's where this whole thing kicked off and really started for us. Christine spent the better part of 6 months telling her story to her pathway to recovery, multiple times to all 280 employees of ours. And I am very proud of Christine and her success. And I think just from a fire and EMS standpoint, being able to see somebody like Christine who has lived experience, who is now fully in recovery and is doing amazing work and great things here in the Roanoke Valley, to us, that brings things full circle. Now, guys and girls that work for us are able to see what they're capable of doing on the other side. And I think fire and EMS historically has struggled to see what that looks like. So with that, I'm going to give Christine a few minutes to kind of talk about herself, her background, and what she does here in Roanoke. Christine?
Thanks, Jason. I am excited to hear all the work that everyone is doing and share a little bit about our work with you all. I am a person in long-term recovery. In May, I celebrated 8 years, and that looked like a lot of things for me. Trauma in childhood, incarceration, state drug court program, a long journey. A 6-month behavior modification program inside the jail was ultimately the treatment that saved my life. And what I really valued from the trainings that I did with all of the first responders is watching them come to terms with the true nature of addiction, that it's not this reckless party lifestyle, kind of constantly chasing this high to feel good, and coming to an understanding of, in the depths of my addiction, I was using against my own will, as I started really transparently and vulnerably sharing exactly what my journey looked like and getting into the great details of that. And them coming up to me after the training and sharing how eye-opening that was, that when they're running Johnny 2 or 3 times a week, there was this frustration of like, well, just stop, just get help. But hearing my experiences, they were able to really understand that the individual isn't in control of necessarily making those decisions at that depth of their addiction. And so, we've seen some of our biggest naysayers in the beginning of the training turn into our biggest cheerleaders as we've gotten into really fully implementing the program and seeing the differences that it's making in the lives of the people that are overdosing, but also for the first responders, the sort of seeing the work in action and seeing how it's making a difference.
Yeah, and I'll just jump in real quick on that, Christine. And that compassion fatigue is real. And that's what I struggled with the most, was not understanding. I didn't understand why we couldn't just put something down. And that was very naive of me. But after meeting peer recovery specialists and having these conversations and getting involved with this, you really begin to understand this as a disease process much more than somebody that's just had a party lifestyle like Christine just mentioned.
All right, Ellen, if you want to advance the slide one. Talking a little bit about options or tools that EMS has on scene to potentially benefit providers or patients that we encounter experiencing overdoses. So one, all the agencies have talked about leave behind kits, pretty common across the United States. The contents is more or less the same, some form of nasal naloxone or nasal Narcan, some basic forms of PPE, and then usually some educational materials. One of the things that we can touch on a little bit later is talking about test strips. So with some legislative changes in Virginia, test strips are now available. They are no longer considered drug paraphernalia. So they are an option for EMS to provide. A lot of the CSBs across the state are providing fentanyl test strips and test strips for other illicit substances. So for people who are using, who aren't necessarily ready to quit, but they're not intending to use a narcotic, whether it be, they're using ecstasy or cocaine or something like that, they are able to test whatever they're using with the test strip to make sure there's not a narcotic in it unknowingly before they use it. There's some stigma still associated with those, and I would love to get Christine's perspective and some of the other panelists' perspective on that a little bit later. Those are one of the things that we are looking to add in Fairfax a little bit later. Support information, this is great. If they are not willing or not in a place that they are able to have a coherent conversation about getting clean, getting help, about harm reduction strategies, leaving that information in the kit so that a couple hours from now, a couple days from now, a couple weeks, a couple months from now, they see that sitting on their counter, they see that sitting on their kitchen table, maybe they will take that opportunity to reach out. So leaving the information behind is also certainly valuable. And then different EMS agencies across the state and across the country have deployed peers in a different way. I think the value of peers is invaluable, that lived shared experience. Some have embedded with EMS agencies, and I would love to get Chesterfield's perspective on this because they've done it a couple different ways. In Fairfax County, we refer to peers who are operate out of our CSB, and then would also love to get an idea what Roanoke and Christine are working on down there. So Chesterfield?
Yes, Steve. So just to just reference that last slide that we had in reference to some of the stories, I did put in the story of one of our MIH providers who is also a certified peer recovery specialist. His main role with us is an MIH provider, but he has been certified. He was in long-term recovery from alcohol, and that story is in there. I'm not going to add any more to that, but just for everybody's reference. So for us, our peers are all either at the CSB, at our CSB, or we have one peer that is specifically assigned to our public safety sector. So she works both in the jails with the sheriff's office, our police department, as well as provides services for the fire department and MIH as well. We have a very strong partnership with our peers. We work with them on a daily basis. We have sometimes weekly, if not monthly meetings as a full team to evaluate how our process of referrals go and how we navigate through those referrals on a daily basis. We're all on teams together. We all text back and forth with each other as far as our schedules and who's available. And they also rely on us as an MIH unit for our Suboxone Bridge program. If they have a patient that is in need of MAT or Suboxone Bridge, we help the clinical side of that, provide that to them as well.
Great.
So this, I'm Alan, I'm one of the medical directors. So there are those that are critics of peers, including myself. When you look at the body of literature and you say, all right, does a peer really help somebody who's in addiction and then on the road to recovery? And the literature is equivocal, maybe, likely has some benefit that hasn't really been studied well. But I think we're asking the wrong question in our environment. I truly believe in the deepest part of my heart that the peers are absolutely essential in engaging somebody into recovery. So not the person that comes in and says, yeah, I want help, and and we assign them a peer. These are the undifferentiated patients who have overdosed, and the peer allows the person who was overdosed time and a resource to get into this system. So having them put in, basically throw the line out there, get the hook, and then reel them in. They're phenomenal at that. And that part of it, of the role of the peer, is not well studied. So there are critics out there, but we're asking the wrong questions when it comes to peers. They are truly essential, but we haven't done the research project to prove it yet.
Great. Thank you, Dr. Yu. Alan, next slide. Real fast, I just wanted to go over, for people who don't have leave behind kits, just an example of what's in the Fairfax County kit. So we originally sort of modeled them off what the Department of Behavioral Health and Developmental Services was using their Revive program. Fairfax County has since started making our own kits, but the contents hasn't really changed. So putting everything together in a bag or a pouch, keeping it together, one, makes it easier for the EMS providers to keep on the rig to hand out, but then two, the parts and pieces aren't getting lost once you've dispensed it to the person at the scene. So we've gone with a little canvas bag. Local vendor made them and screen printed them for us. They, I think, are less than $1, $1.50 a piece in bulk. So not a big deal. And then beyond that, nasal Narcan, some basic PPE, barrier device mask for doing rescue breathing, some gloves, an instruction card One of the things that I would say is EMS should not assume any knowledge from the person that you're dispensing to. And when you're dispensing the kit, at least take a couple of minutes to offer some basic education in terms of what to look for, signs and symptoms of an overdose, the basic response to an overdose, and remembering to call 911, how to administer the nasal Narcan, how to use the barrier mask, things like that. We take this for granted, and you might laugh, but we've seen nasal Narcan administered by bystanders, well-intending bystanders, into the patient's ear instead of into their nose. So that said, it is absolutely worth 5 minutes of effort by whoever's left on scene, if the transport unit is already left, to do some education with that roommate, with that family member, with that friend. We include within a bigger kit that this kit we're dispensing lives in, a laminated card with some teaching and talking points for our providers who might be newer or might be a little less comfortable with providing education to a patient or family member. But honestly, the vast majority of our providers, the thing they find easiest and most effective is just to take the contents out of the kit and go through each piece with the person. And they find that that's adequate enough. The person will ask a lot of questions if they're not familiar with something. And then tangentially related, Ellen, the last is ask them if they already have Narcan. If they have a friend, if their friend, family, roommate, loved one has a known opioid use disorder, it's entirely possible they already have Narcan. But depending on where they've gotten it from, it might not be an optimal delivery method. So ask to see it. There are some groups and organizations across the DMV and across the state of Virginia that are still providing the Narcan and Bristol-Jets with an atomization tip. If they have it in this form, I would highly recommend still providing them with a replacement prepackaged nasal spray. Every narcotic overdose that I've ever run where the friend or family has had one of these Bristol-Jet kits, they didn't actually end up administering it because, you know, in the panic of the moment, they couldn't remember how to put it together and to deliver it. So switching out to the prepackaged nasal sprays where literally 2 steps to administer it is a much better option for them. You don't need to take the old Narcan away, but I would highly recommend and encourage your providers to encourage them to use the prepackaged nasal sprays. Roanoke, Chesterfield, anything to add?
No, Steve, not on that. We're not doing any leave behind stuff. All of our leave behind our stuff is coming from community partnerships through Bradley and some of the outreach stuff that's going on through them. We're not doing any direct leave behind stuff.
No, and we have a very similar kit to that as well, with resource cards and instructions. And our providers are also asked to ensure that when they give it out, that they have a conversation about usage with the family member or patient.
Awesome, great. Ellen, next slide. Just real fast, I wanted to give you an example of what Fairfax is providing for our port team, our peer outreach response team. Just a simple card that fits inside the pouch. You can obviously scale it to whatever size pouch you decide to use. But basic information, a little bit about what the peers are, a little bit about the potential services that are available if you call the number, how to get in contact with them. And then once we had this printed, we had it translated into the 8 most common languages spoken in Fairfax County besides English. So we prepackage all of our kits with English and Spanish because those are the 2 most predominant languages, but we have a little tiny, for lack of a better word, baggie or pouch next to the dispensing kit that has the other 7 languages in it, so that if we come across somebody who speaks a different language, we still have the opportunity to provide them with the information in a format that they can understand. Ellen, next slide. Real briefly, because I want to leave time for questions, I just want to give you an example. If you're doing any efforts regarding opioid treatment, whether it's leave behind kits, whether it's connecting with peer services, whether it's induction, things like that, documenting it is key. 1, to show effectiveness. 2, if you're applying for grants, to show, you know, benefit of utility. So this is just an example of what it looks like on our patient care report. On the right-hand side, if this is who are we dispensing the leave behind Narcan kits to. On the left-hand side, if we're trying to connect them with peer services, making sure we get a contact phone number. That's not something we normally require our providers to get of our patients. But if we don't have a contact number, the odds of our peers being able to successfully connect with them go down dramatically. We can try to get it from the hospital, but if they have a tendency to refuse at the scene or they don't provide that information to the hospital, it's not a guarantee. So if we can get it on the X while we're doing our report, all the better. All right. And then Chesterfield's already, sorry, go ahead. Go ahead, Chesterfield.
All right, next slide. Next. So fiscal year 2024, basically July of 2023, we started a Suboxone program. Suboxone, methadone is probably one of the more well-studied interventions for long-term recovery. It's shown to be beneficial. However, there's a lot of stigma with it, and it was very difficult to initiate. You used to have an X waiver, so only limited docs could do it. But with the pandemic, opioid pandemic, the X waiver has been removed. Now ED docs, any doc can prescribe Suboxone. Several EMS agencies across the country started giving Suboxone at time of overdose. Well, we're headed in that direction, but what we chose to do is we've chosen to use our MH providers and give Suboxone to patients who want it. So typically they're 24, 48 hours after the overdose. The peers bring to us, or we encounter them, and we just basically do a video visit, televisit with me, and I write prescriptions. You know, we started off at varying doses of Suboxone. If somebody, and we use the COW score, the opiate withdrawal scale. So if you're really, when we started this, if you had a high score, we'd give you more Suboxone. If you've had a low score, we'd give you a little bit of Suboxone. Kind of intuitively made sense, but it was probably the wrong thing to do. So our current strategy now is basically everyone gets 16 milligrams of Suboxone for a prescription for that for X amount of days. We write the prescription, and it goes to the pharmacy. Our CSB pays for the medication, so we ensure that the person actually gets it. They also pay for comfort meds like clonidine, Zofran for nausea, Imodium for diarrhea, and medicines for anxiety and body aches. So we've had a variety of different methods that the patient takes Suboxone. So we have had the patient take the Suboxone in front of our MIH provider. This way, if they get sicker, the MIH provider knows what to do. Or more recently, we've created a handout to the patient. Says, all right, go home. When you start getting really sick, we want you to take 2 strips of 8 milligram Suboxone. They do that, and then in 45 minutes, if you get sick, if you get sicker or it gets worse or your symptoms are intolerable, take another 2 strips, and for a total of 4 strips a day. And we write enough Suboxone until they can get in front of the CSB or other community partner for long-term MAT. I think we've been very successful with the 38 patients we did in fiscal year 24, and we've probably done another 10 or 12 in July and August. So it's starting to ramp up. Most of our patients have continued in long-term recovery. We have had one case of withdrawal, but that we were using low dose Suboxone at that time. This Suboxone, I can't speak more highly of. It is so easy to prescribe. But there is a lot of stigma because people have heard about this precipitate withdrawal, and a little bit of education with the patient goes a long way. Next slide. So for our plans for our future, what we want to do is actually start field inductions in the ambulances. We're trying to just see if we can design a pilot where our districts with a high incidence of opioid addiction will actually have some Suboxone in the unit. So after an overdose, we give them Narcan, and we displace basically the fentanyl off of the cells, and then we hit them hard with 16 milligrams of Suboxone as long as they consent. That's something we're trying to design. And the VCU Addiction Fellowship is actually assisting with us on that. And then we've also looked at transporting to alternative destinations. Like what we want to do is utilize one of the freestanding emergency departments in our county as a dedicated opioid drop-off site where we're partnering with the ED docs saying like, hey, if EMS started Suboxone, we want you to finish it. Or if EMS doesn't start Suboxone, we want you to start it and then call MIH after their discharge and the peers, and then we'll pick the patient up and make sure that they continue on their road to recovery. That's something that we're thinking of, and I'll turn it over to Fairfax.
That's great. Yeah, from a Fairfax perspective, we're looking at starting to do something similar in terms of field induction and then selective or alternative transport destinations. We've sort of planned it now. I think our EMS specialists, our advanced practice paramedics, are going to be the ones who will be doing the field inductions, appropriate patients called to the scene. And then we're also looking at transporting to places other than the traditional emergency departments. Within Fairfax, the fire department's always had a strong working relationship with our community services board. And so recently, we've sort of talked about transporting to them rather than to the ED. Ellen, do you want to speak on that a little bit?
Sure. So we're always kind of monitoring this post-overdose follow-up and engagement. And so we have been looking at how we can get folks engaged more quickly. And one of the options that we're exploring is whether our EMS providers could, bring patients to the CSB's addiction medicine clinic. And that addiction medicine clinic is a team of folks who focus on doing medication for opioid use disorder currently. But right now, what we're looking at is really how we can get people engaged in that very, very quickly. So, within 24 to 48 hours. And so that's something that's on the horizon, and more to come on that in the future.
Great. Next slide. Tony, do you want to speak a little bit about what's available to EMS agencies across the state?
Yes, thank you very much, Steve. So before I jump into this, just a reminder to all of our attendees, if you have questions, comments for the panel, please click on the Q&A box at the bottom of the Zoom screen, and you can type in your questions, and as moderator, I will read them so that panel members can answer. Okay, so what kind of resources are available to support fire and EMS agencies across the state, and specifically what type of opioid settlement funds are available? So hopefully you've heard some of this information already, but Virginia is going to be receiving a little over $1.1 billion over the course of all of the different settlements. And of these funds, 30% will go directly to our cities and counties. In other words, not through the Opioid Abatement Authority, but directly to your city or your county. And each city or county then is required to use those funds for approved opioid abatement remediation purposes. Everything that we've talked about on this webinar today would be examples of allowable uses of these funds. And so while a certain amount of the money goes directly to cities and counties, most of it comes to us here at the Opioid Abatement Authority, and we use that money to give additional grants to cities and to counties. In fact, 15% of our grants, of our funding, is available for cities and counties on a non-competitive basis, which means that there's a certain amount of money that each city and each county is entitled to receive from the OAA. They just have to ask for it. And we review the application and make sure that the proposed use is consistent with the requirements. And if it is, then we transfer the money. It's that simple. And then 35% of our funding goes towards competitive grants that are of a regional nature. We call these cooperative partnerships. And in fact, all three of the municipalities that are represented by our panelists today have been receiving both the non-competitive and competitive grants from the Opioid Abatement Authority. Ellen, if you could go to the next slide. Just to give you an idea of where you would find this, this is a screenshot of our website at voaa.us, and you click on media and documents, and at the bottom of that page where it says resources for cities and counties, there's a link that allows you to open up a Excel file. And Ellen, if you'll advance again, this is an example of what you'll find when you click on that Excel file. You can choose which city or county you're from or that you're interested in, and it shows you all of the different types of distributions of funds that are available on a non-competitive basis. So the money that the locality gets directly, the amount that's held for you by the OAA, and amounts that are available to you as an incentive. Next slide. So how would you go about applying for a grant? Well, the grant has to come from the city or the county executive, if you will. So you have to run it through your leadership. It can't come directly from the fire chief. It has to come from the, really from your board of supervisors, city council, whoever's authorized by your governing body to apply for grants. But certainly these start at the department level and work their way up to the chief executive. Applications open for cities and counties every year on October 1st. And the application period is open all the way until April 1st. The grants that are non-competitive are awarded on a rolling basis. The competitive ones, we have to wait until the grant period closes so that we can look at all of the applications and choose or select which ones that we can fund. And all of the information about these grants and how they work can be found on our website. Again, it's voaa.us. Next slide. For more information, we put this in here because, as I mentioned, a lot of people will wind up accessing either the recording from this webinar or looking at the PowerPoint after the fact. And so if you have questions that you didn't want to put into the Q&A, or if you want to follow up for more information, these are the primary points of contact for Fairfax, Roanoke, Chesterfield, as well as myself for the Opioid Abatement Authority. And if we'll go one more slide, I think that's the end. So we do have a question in the chat, or excuse me, in the Q&A that says, could the panel share how they are, or ideas for ways their work can help inform upstream prevention efforts? So for example, data, trends, and or human stories they encounter that could help inform upstream prevention efforts. Anybody from the panel would like to address that question?
Hey, Tony, I think Christine can answer that question pretty well through the HOPE initiative and the partnership there. And it's also important to remember that that collaboration that we have with them is a state resource. Yes, it's based out of Roanoke, but if I can share my screen real quick, Ellen, if you'll give me those permissions just real quick, I can kind of show you some of the data, what it looks like here in the Roanoke Valley and some of what we've been able to do.
Jason, we're making you a co-host real quick. That'll allow you to share your screen.
Okay.
While Jason's getting that up, I'll go ahead and kind of just start talking about how the program operates. Similarly to, as Jason shared earlier, we within the HOPE initiative program at Bradley Free Clinic met with the Chesterfield peers and the program that they were doing, gosh, back in like 2019, and sort of learned from the work that they were doing and began building a program that worked here in Roanoke. And ours is based strongly off of having a peer housed at the station with fire and EMS to go as ride-alongs on scene to overdose and substance related calls. And that took some time really to sort of iron it out and see what worked within each locality. But this is just a quick snapshot since the first of this year when the program was fully implemented and went full time, having our peers who, again, it's a partnership between Bradley Free Clinic and then the fire and EMS department. And so since January, we've gotten 118. The referrals are really the connections where a peer was on scene with fire and EMS and made that connection with the individual. 104 of those were unique individuals, which shows as we get further down this information quickly, only 13% of those are sort of the return or the frequent flyers as we often know them. There's a quick breakdown. Our heaviest involvement is with Roanoke City. We do work within Salem City and Roanoke County as well. And out of those 118 connections, 37 of them resulted in interviews. So that is 36%, which 7 months into a program really, I think, is great success. You're seeing that those return numbers are lowering because we're connecting with those individuals and providing them support and connecting them with resources. And we're hoping to see that those sort of frequent flyer return numbers drop. We do continuous outreach with those individuals from the moment that they connect with them and accompany them to the hospital during transport. And you see there sort of the number of outreaches that are conducted after that connection is made. But I think really most importantly, what you see down here at the bottom is the admissions. 51 admissions into some type of treatment or recovery program of their choice. 90% of those individuals are connecting into more than one resource. 62% of those interviews resulted in a treatment admission. So it's getting in there, as one of, I think it was Thomas had mentioned, it's getting in there, casting the line, planting the seed, connecting with that person in a very non-judgmental, compassionate stance as a person who's been in that exact same position, and continuing to support them as they find that willingness after that sort of moment of crisis. We would love to talk more deeply about this program with anyone that's interested. I realize we're tight on time, but I really wanted to make sure we got some of this data out there to share with you guys of the great successes that we've been seeing this year.
Thank you, Christine. I think it's really remarkable because we're not talking about something that you guys have been doing for 10 or 15 years. This is all very recent. And so those are very promising results. Let me, if I can, for the panel, I want to try to ask the question that was in the Q&A in a little bit of a different way, which is, as your providers and your peers are interacting with people who've had these opioid overdoses or opioid emergencies, are you seeing anything that drives discussion about prevention on the front end? Are you hearing sort of common thread stories about maybe something that could have been done to prevent this from occurring in the first place? Any thoughts on that? I mean, we're all sort of, as for folks on the call that come from the fire and EMS service, we're always thinking about preventing the emergency. So I'm wondering if there's any comments from the panel about that topic.
This is Ellen from Fairfax County. So just a couple thoughts on that. Steve touched on this earlier about kind of the need to really educate people when you're doing Narcan training and kind of what happens when folks don't really fully understand how to administer Narcan. And so that has been kind of a lesson learned for our team that we've filtered back to various other teams throughout our cross systems opioid response, really underscoring, you got to go over the basics with people. You can't assume that because it's the nasal kind where it's, relatively easy, put it in the nose and spray, that everyone understands that. So that's certainly one piece that has informed our prevention work. We also have the work that Steve described in this webinar was really focused on the fire and rescue kind of touch point, but our post-overdose follow-up in Fairfax also involves our police department, of course, our community services board, several other teams. And so part of what we're looking at on a regular basis is that feedback loop. And so looking at, are there, we meet regularly and we talk about, are there common challenges that we're seeing in terms of engaging with folks in follow up, and what can we do about that? And so as the prevention sort of, as items that can inform prevention rise to the surface, we do filter that back. But I think the best example is really that education of bystanders around the Narcan.
And as I begin to recognize Christine, who has a comment, this is sort of the last call for any of our attendees who would like to type a question into the Q&A box to go ahead and do that now. And I think Christine has a comment. She might get the last word.
I'll keep it brief, but this seems like a perfect match to someone who was presenting said was seeking sort of my feedback on fentanyl test strips and the stigma around those, but really that is a form of prevention. If individuals are able to test the substances that they're using for fentanyl, that's going to prevent that overdose. But then there's a lot of other additional community conversations and education that we do sort of separate from this, that is centered around schools, churches, employers, around understanding the disease of addiction to hopefully prevent individuals from getting to that point of their substance use, and understanding the resources for treatment and recovery that are out there for them. we can only help people if we can keep them alive. And if that means Narcan or fentanyl test strips, then that is really a form of the prevention to be able to do that.
Great. Well, thank you for that comment, Christine. And I'm not seeing any new questions popping up, so let me just take a moment as we wrap up to offer a huge thanks to all of our panelists who participated in this effort voluntarily. There's no compensation for any of these folks other than doing the right thing. And I know that several of you were or are on vacation and carved time away from time with your family to help spread the good word of what you're doing. I think that you're on the cutting edge of something in Virginia, that these overdoses are killing more Virginians than anything else that fire and EMS agencies are responding to. And so you're really to be commended for your work. And thank you again for your time. To all of our attendees, again, we post the recording and all the materials on our website. Those should be available in the next few days. Certainly by Monday, if you check back, you'll be able to access them. So one last plug, our next Abatement Academy will be on August 29th, and we'll have representatives from the Virginia Department of Health participating in a webinar to talk about the statewide naloxone distribution plan, which will include topics about how your agencies can obtain either no-cost naloxone or naloxone that's available with special pricing to public entities. So with that, thank you again for your participation. Have a great day.